We've been doing things using whole mount prostatectomy data for some time now, a whole mount, and I'll show you the whole mounts and how we can gather data that we can't normally gather using normal pathologic techniques. And we've been doing that long enough that we could really look and see changes over a period of time. And the other reason is that during this 16-year period of time, myself and my partner were the only two pathologists who were grading prostate cancer. And my partner, I trained. So it was pretty much clear that we could have a better study with only using a central pathologist approach here. These are my disclosures, none of which are really relevant for this talk. So it's clear that over this period of time, the prostate cancer landscape has changed. We saw a shift in clinical presentation over the PSA era. In the 90s and 2000s, with the advent of PSA, over time, what we were seeing is earlier stage disease and lower PSAs. And if you look at the data from the Department of Defense Center for Prostate Disease Research data, during the decade where we really introduced PSA, what we saw over time was an increase in the number of non-palpable tumors being diagnosed and sent on to prostatectomy, and a decrease in palpable tumors. And if you look at PSA data during that time, you see that by far the biggest increases occurred in lower PSA values. So you saw the biggest rise in the 4 to 10 PSA range, and even a rise in the less than 4 PSA range, with a concomitant drop in those with more advanced stage. And this is a surrogate for tumor volumes here. So we believe that the tumor volumes decreased over this period of time. Well, then more recently, we've seen a shift in screening. Recognizing that we were now seeing smaller, earlier stage tumors, we realized that we were probably over-treating biologically indolent tumors, tumors that wouldn't really affect the patient's health over his expected lifetime. So, as you all are aware, in 2012, PSA received a D rating from the Preventive Services Task Force. Now, this has been subsequently modified to a C rating last year, but the damage really was done here when we really saw a recent decline in prostate cancer diagnosis. And if you look at the SEER registry data, it really shows that quite well. This is looking back almost 40 years now. You can see the blip that occurred with the advent of PSA. That's the harvest effect that we saw there. And yes, there's been a decline in prostate cancer diagnosis steadily over the last decade, but a very precipitous drop more recently. So that we're really seeing numbers of new diagnoses which are really reflective of what we saw in the early 80s. Now, in parallel with this over-treatment dilemma, we recognized that not all cancers needed treatment. And so we also saw the emergence of active surveillance and for targeted focal therapy for low-risk prostate cancer. And I think this next slide is kind of startling when you look at the CAPTURE registry and see, let's just focus here. This is types of treatment for prostate cancer, and just focus on this light blue bar here. Well, this is active surveillance. And you can see that active surveillance took a big increase in low-grade cancers. These are CAPRA scores of 0 to 2. Low-risk cancers here, up to almost 40% of those cancers in this registry being handled by active surveillance. A big increase, and it really occurred around 2010. Now, pathology also changed a bit over this last period of time. Whoops. What just happened? Oh, there we go. Okay, we back up? All right. We have a shift in pathologist grading practices. That's the International Society of Urologic Pathologists, ISUP, modified some of the ways that we report Gleason scores in 2005 and 2014, and the advent of the prognostic grade groups. So here's where we are now in terms of prostate cancer grading. We still use the Gleason grading system. It's a myth that the new prognostic grading system is a new grading system. It's just a classification of ways to group Gleason grades. The Gleason grading system for years has been an architectural grading system that looks at the morphologic resemblance to normal prostate and the degree of invasiveness. And Gleason originally put this wallpaper up so that you could see what he was talking about. This has been modified. This is using the ISUP 2014 modifications. But at the low end, you see small acini composed of cells which look a lot like normal prostate cancer cells, and they're grouped into acini, so they're differentiated and they're not very invasive. They have this nice rounded border, for instance. All the way to the other extreme where you have cells that don't know how to make glands anymore. They just make sheets of cells or even single cells, total anarchists at this point, and everything in between. And of course, the Gleason grading system also recognized that tumors were often heterogeneous in terms of grade, and had more than one grade pattern, which affected their overall prognostic significance. So he combined the most prevalent pattern with the second most prevalent pattern. So if you have a lot of this and a little bit of this, it would be grade 3 plus 4 or a score of 7. Now what the ISUP looked at was a lot of data armed with mountains of data to indicate how bad tumors did when they had these various patterns. It kind of shifted the grade patterns around a bit. We recognized that the amount of pattern 4 and 5 were the most important in terms of relevance. And so we really concentrated on this end. And what we saw with the refinements adopted in 2005 particularly was that certain things that had been called Gleason pattern 3 before were shifted up into the pattern 4 area right here. So we made things a bit more stringent in terms of calling Gleason patterns 3 or below. Now, this is borne out in terms of relevance by a number of studies, but the effect overall will be that you will see a grade shift towards higher grade tumors. And this is a study out of Canada that kind of exemplifies that. So what we've got here is the same group of pathologists, and they just recorded their data for the number of biopsies that they graded as Gleason score 6 or below, Gleason 7 or Gleason score 8 or above, up to the ISUP 2005 recommendations, and then after. And what you can see is those that were called Gleason grade 6 or below went from about 2/3 of their cases to a little over half, and that there was a concomitant increase in Gleason 7 specifically, and even some Gleason 8s. And as expected, this was due to the secondary grade pattern in the Gleason scoring system. So those little bits of pattern 4 that used to be ignored now were no longer ignored. And so Gleason's 3 plus 3s became 3 plus 4s. And that is the increase in grading that we saw with that. So the relevance of this is borne out by a number of studies and validation of this new concept. But I think this is one of the best that I've seen. This is data from the Harvard group looking at almost 700 patients from the Physicians' Health Study who underwent prostatectomy and then following their mortality statistics over the next 20 years. And you can see what they've done here. I've lost the pointer, so I'm going to have to use this. What they've done here is, this is the Gleason score here, between 2 and 5, 6, 3 plus 4, 4 plus 3, 8, or 9, or 10. And this was their original grading over this period of time. So before the refinements of the ISUP. And you can see the grade stratifications here and the number of patients that fell in each grade category. Look at the mortality rate over here. What they found, even with low-grade cancer at prostatectomy, patterns 2 to 5, you still had a very low but real mortality rate, and also with Gleason 6s. And look at, there's a lot of wobble in the mortality rate as well. In fact, it looks like 4 plus 3 is the worst thing you can have here in this data. So there was a lot of variability. Then we went back in a Herculean effort and regraded all of these using the more modified Gleason scoring system, and you can see that there's a shift towards higher grades. These numbers shift towards the higher grades. But look what happens to mortality rates now. Now it's a much more smooth distribution. You can see that there's much more prognostic value from classification to classification, and there were no deaths in Gleason pattern 6 or below. So this really forms the basis of why we do the prognostic grade groupings that we do now. And the prognostic grade groups are just a way of classifying the Gleason scores into something that is a little bit more meaningful for the patients. Gleason score 6 or below, prognostic grade group 1. And then really with increasing amounts of high grade patterns, 4 and 5 is where you get your prognostic groups. 3 plus 4 would then be a 2, a 4, 3, a 3. If it's all 4 or has some 5, 3 plus 5, for instance, in it, it's a group 4. And of course, the higher groups are the worst. And so this is now the kind of the standard that we use. We report both the Gleason grading system and the prognostic grade group score. So what does this mean? We have not only a shift in our grading practices, which could certainly cause a shift towards higher grade tumors, but we have all of these changes that are occurring clinically, so that we are changing the selection of the clinical parameters for the patients who are going on to go to prostatectomy. So we asked the question, what would be the impact of this on the tumors that we're seeing at prostatectomy? Well, here's what we thought. Certainly with the ISUP grading system, there would be a shift towards higher grade. We've already seen that, so we expected that. But what would happen with an increase in active surveillance? Well, what you would hope is that would be a relative decrease in the low-grade cancers, right? We would remove those from the surgical pool. That would give you a relative increase in higher grades, but it would be proportional because really all you're doing is removing the low-grade tumors. But what would be the effective decrease in screening? We would hope that it would have an impact on low-grade tumors because those are the ones that we're worried about are being overtreated to begin with. But would this cause us to have a delay in the natural history of prostate cancer so that we're interrupting it at a later time point? In such a situation, we might have a disproportional increase in high-grade tumors, and we might see an increase in stage and volume. So we went back and looked at our University of Colorado prostate cancer database. These are all prostates that were whole mount processed, and I'll show you what that is in a minute, graded by just 2 genitourinary pathologists, and that we had complete data on grade, stage, and tumor volume because of the way we do the whole mounts. So what we do with a whole mount is we take out the prostate, you give it to us, and then we essentially cut it like a loaf of bread every 4 millimeters or so from apex to base. We then mount those on large format slides. Not an easy process to do because these are twice as big as the typical pathology slides that we do. But once we do that, we can draw out the areas of tumor by grade, and as I'll show you in a little bit, we can reconstruct them to show tumor volume. So you can get very accurate grading information, staging information, and of course, as you see here, multifocality information. So here's our results over the 16-year period. These are Gleason scores of tumors all graded by just 2 pathologists. And what you can see nicely over time is a big drop in Gleason 6 tumors. Really starting about 2010, we see this precipitous drop. Going from when we started the study, about 40% of our cases were graded as Gleason 6 or below to virtually none at this period. Now again, this could be due to our grading practices and a combination of active surveillance. And notice you'll see this concomitant increase in the number of high-grade tumors. Another way to see this data is to look this way. Here's a pie chart showing we combined a couple of years here, but at the beginning of the study, 2002, 2003, and you can see the proportion of tumors graded as Gleason pattern 6. Some of them had no grade. These are tumors that were not gradable due to neoadjuvant hormone therapy. But that's the percentage that we see here. Notice what we have now. Less than 2% of our cases are Gleason 6s now that are coming to prostatectomy, with large increases in these others now. The next slide is very important though, because this really shows that it's not a proportional change. If we were just eliminating Gleason pattern 6 from the surgical pool, everything else should grow proportionally. And that's not what's happening here. You see, by removing the Gleason 6 tumors, what you see here is we've more than halved the number of 3+4 cases that we're seeing over these 2 time periods, but we've had a 5-fold increase in the numbers of Gleason 9 and 10 tumors. 5-fold increase. So that's pretty startling. Is that all due to just us pathologists overgrading things now? Have we gone too far? Well, it certainly could be due to grading practices, and that's a concern. But some of the other factors that I pointed out could also have impact. You certainly can't blame Gleason grading practices on these data. And this is looking at stage data over the same time period. You can see at the beginning of the study, less than 20% of our cases were non-organ confined, PT3 and higher. And that it stayed relatively stable up until about 2012, and then there was this sudden and sustained increase in the number of cancers that we're seeing that are no longer organ confined, that are pathologically advanced here. Almost 50% of our cases now are PT3 and above. And look what happened to lymph node status too. Less than 2% back then. Now we're approaching 10% of our cases now have lymph node metastases. This is not a product of overgrading at this point. This is a product of we are seeing more advanced stage tumors. We're seeing tumors at farther down on the natural history of prostate cancer than we used to before. Another nifty thing that we can do with hole mounts is once we've drawn them out here like this, we can trace them onto acetate sheets. Next slide. Then we can, next slide, we can run those sheets through a computer. Next slide. Go through a number of processing steps. Next slide. And eventually, one more, put it all together in a 3D reconstruction here. And so this is one of our prostates. You might barely be able to see the shadow here in white here. That's the whole prostate. And what we've done is highlighted a few features in color here. The blue is the urethra, making its normal 45-degree or so bend in the prostate. And two tumors here. There's a little anterior tumor there in the transition zone. And then here's this big green tumor out here. And it shows a number of things here. Multifocality tends to be the rule here, and that tumors are very rarely round. They're usually these big star-shaped things that grip on. Remember, the sign of cancer was the crab, meaning that it had claws that hooked into the flesh, and that's exactly what you're seeing here. With this, you can get very accurate data on tumor volume. And my former mentor, the late, great Dr. Gary Miller, was the first one to really use this technique, and he showed way back in 1994 that tumors were often multifocal. So his study, again, 1994, was looking at all prostates before 1994, the majority of which were pre-PSA era tumors. Only about 20% of the cases that he did in this study were after PSA. And what he saw at that time was about 56% of the time prostates had more than one tumor focus within them. In fact, it averaged almost 2 foci per patient if you looked at it, 1.9 foci of tumor per patient in his study. And look what happened with tumor volume. By far the largest tumors were in those prostates that only contained one tumor. So he reasoned that the cause of that was that one tumor didn't start out that way, that this was a conglomeration of tumors that grew together over time, and that's why you had that, and that's why it was such a dramatic increase here. And you can see the mean tumor volume of his group back then was 4.5 centimeters, so these are huge tumors. If he was right, then the PSA era should have had an effect on that, and it did. Here we've looked at 10 years of our study, just looking at deeply within the PSA era time point up to 2012 before the task force made its declaration here. And you can see that multifocality went up. Now 72% of our tumors were multifocal, had more than one focus of tumor in it. And that the number of tumors per patient went up. There was 2.7 foci of tumor rather than 1.9 here. So he was right in that state. And the mean tumor volume decreased considerably. It had gone from 4.5 down to 2 cc's as our average tumor volume. That's for the index tumor. Well, look what happened in the last 2 years. We've just looked at the last 2 years' data. We still have a lot of multifocality, but the number of tumors per patient is starting to fall. It's intermediate between what it used to be back then and what it back in Gary's day and what it was with PSA era. And look what's happened with mean tumor volume. we've gone from 2 to over 3.5 centimeter tumors. So the tumors are not only advanced stage, they're larger and that we're seeing now. Now what's harder to understand is what's going on here. In terms of the location of the dominant focus of tumor, we've seen a 25% relative increase in the number of cases that are in the anterior portion of the prostate over time. We don't really completely understand that. That may be a product of the natural history of prostate cancer. Or are we seeing truly different tumors these days than we used to see before? We don't know, but we're going to be following this to keep an eye on it. So our conclusions with this is that we know that there are changes in the way we clinically manage prostate cancer. Patient selection going on to prostatectomy, combined with the pathology changes that we've seen over time that have led to changes in the tumors that we're seeing at prostatectomy. There's been a shift towards higher grade tumors, which is likely multifocal. It's likely due to pathology practices, an increase in active surveillance and targeted focal therapy, particularly at our institution, and unfortunately, probably picking up tumors later in their natural history. What that impact is on mortality, we don't know yet. It's too early for us to do that part of the study, but we'll keep you posted. Next slide. I'd just like to acknowledge, make some acknowledgments of who make this study possible. My partner in crime is Dr. Francisco La Rosa, a genital urinary pathologist that I trained. Priya Hera actually put together the software that allows us to do the 3D reconstructions. Kathleen Torko is our statistician. Adri van Bachhoven runs the biorepository core facility, which helped us pull all the cases for this. And then my good staff of technicians who helped us do all the hole mounts for this study. And with that, I thank you.